Welcome. We are going to be talking about the pharmacokinetics that you need to keep in mind when patients have thyroid disease. As you know by now, thyroid disease is quite common, and we're going to talk about what things might change as far as the drugs, thyroid drugs themselves, as well as other drugs that patients take that have thyroid disease. So I'm not going to go over all these. I think you guys should be able to read these on your own, but these are some of the things I look at when I make test questions. So the thyroid hormones, as you know, we are mostly interested in T3 and T4. And of course, you know, one of my interests is protein binding. So look at this plasma protein binding of these two hormones. T3 is 99.7% bound, so very highly bound, right? Bound to both thyroid binding globulin and albumin. So very highly bound, but only to be surpassed by T4, which is 99.97% bound. So itty bitty changes are going to make big differences in the amount of free T4 and free T3 that are available to do their thing in the body. Also notice that the more highly bound T4, which is less active, right? The real active component is a T3. Has a much longer half-life. So T4 has a half-life of about 7 days, and T3 of only a day and a half. Again, T3 being the active component. So you want to keep that in mind, that both of them are very highly protein bound, not only to our usual albumin, but to some specified proteins specific proteins for thyroid called thyroid binding globulin. Ooh, isn't that shocking? And thyroid binding prealbumin. All right, so we would be interested in things that are going to change those binding proteins. You already know what changes albumin, but what changes this very specific protein called thyroid binding globulin? Well, you can see increases in the amount of thyroid binding globulin, which would make an increased capacity for the binding and therefore more highly bound and less free would be available. In pregnancy, estrogens, oral contraceptives, so you're all on the same theme there, tamoxifen, so all these estrogen drugs, heroin, methadone, midotane, and clofibrate. Clofibrate, midotane, you may see these more commonly. Things that would do the opposite, decrease the amount of thyroid binding globulin around, so estrogens increase and androgens and glucocorticoids decrease the amount of thyroid binding globulin around. The pregnancy thing might be a reason why we have to give more thyroid to patients that are pregnant. Things that will displace thyroid from the thyroid binding globulin, therefore increasing the free fraction, would be salicylates and furosemide. As far as I know, we don't see this, or maybe it hasn't been put together clinically, but this has been seen in vitro. So thyroid hormones like a drug, have to be cleared. So T4 is the inactive form, which needs to be deiodinated in the periphery to make the active T3 form. About a third of T4 turns into T3. You also can have some peripheral deiodination to an inactive T3 form called reverse T3. About half of the drug goes that way. And then the remainder gets conjugated to make a glucuronidate in the liver. So we'll talk about that a little bit more too. And then, interestingly enough, those glucuronidation metabolites then go on to be secreted into the bile, which can then be enterohepatically recirculated by being reabsorbed in the small bile and go through the process again. Also note that I've put that they're beta blockers, corticosteroids, amiodarone, and PTU can all inhibit the peripheral deiodination or the activation of from T4 to T3. So in order for T4 to be activated, it has to be deionated, as you know. Beta blockers, corticosteroids, amiodarone, PTU, and ipodate can all block that from happening. So what's important here is that you know that these drugs can inhibit this conversion, are important, especially in a thyroid storm situation. This would be, one of these drugs would be the best thing to give to try to stop that activation of the T4. So we talked about the different forms of clearance. So as we said, if you want to decrease the peripheral conversion to the active T3 form, you give one of those drugs I just mentioned, amiodarone, PTU, propranolol, beta blockers in general, glucocorticoids. Now let me go back. Propranolol is the prototype for a beta blocker. What you don't want to give is a beta blocker. If you want to stop thyroid storm, you want to make sure that they don't have any ISA activity or intrinsic sympathomimetic activity. Make sure you know which beta blockers have ISA and which ones do not, because you would never want to give a drug with ISA as a beta blocker if you're trying to help treat a thyroid storm. Also, glucocorticoids do this. Okay, make sure you know those ISA drugs because you want to avoid those. Hepatic enzyme induction would increase the clearance of the T4. So those enzyme inducers like phenytoin, DPH is phenytoin, CBZ is carbamazepine. These are two anti-epileptics. Phenobarbital is another anti-epileptic. So phenytoin, carbamazepine, phenobarbital, all anti-epileptics that will increase the glucuronidation of the T4. Rifampin and rifabutin also will increase the enzyme activity and therefore increasing intrinsic clearance, basically. Cholestyramine and cholestyramine are both anti-cholesterol drugs that will bind up the drug once it gets into the gut again. When those metabolites get into the gut, it will bind up the drug and go out in the feces rather than being reabsorbed. So you see an increase in the fecal loss with those two anti-cholesterol drugs. They're biosequestrants. So here's some other things that will change the bioavailability. Those things were clearance issues. Here's bioavailability issues. It seems that thyroid is quite tricky and many things will alter the bioavailability. It's best if the patient takes it on an empty stomach, which is kind of a pain. 60 minutes before you eat. I know my mother takes this, so many times our breakfast plans are a little delayed because she wants to take her drug and then wait for an hour before we eat. So it's a little bit of a pain in the neck sometimes, but important to get reproducible results in some patients. You also have things, if you have diarrhea or constipation, those kinds of things can alter the enterohepatic recirculation of the drug. Other things that will decrease bioavailability are increases in soy protein in your diet, estrogens, we already talked about cholestyramine, iron, antacids, sucralfate, calcium, aluminum, raloxifene. These can all, again, bind up the thyroid in the gut and decrease bioavailability. It's really important to know in pregnancy, and I'm sure other people have mentioned this, but in pregnancy, we talked about the fact that estrogens and pregnancy itself will increase thyroid binding globulin. So you usually have to increase your thyroid dose by 25 to 50%. This is really important because if the developing fetus doesn't have enough thyroid available, it can not develop properly and have cretinism, which is a profoundly devastating disorder with the baby being mentally retarded and dwarfism and all kinds of difficult things to live with. So it's really important that we check this with our patients when they become pregnant or even when they're thinking about becoming pregnant so that they get that increase in their thyroid dose. There also could be, obviously we talked about the thyroid binding globulin thing, but Many of these patients are also taking calcium or iron, which can also bind the thyroid, decreasing the bioavailability. Things that will alter thyroid stimulating hormone. Remember, it's a dopaminergic system that controls this. So dopamine agonists will decrease thyroid stimulating hormone secretion and the thyroid releasing hormone response. So dopamine, dobutamine, levodopa, glucocorticoids, bromocriptine, and octreotide will all decrease the TSH. And obviously the yin to the yang, the dopamine antagonist will increase thyroid stimulating hormone secretion. So dopamine antagonists like metoclopramide or doperidone will increase thyroid stimulating hormone secretion. So these things will alter TSH secretion. Things that will decrease thyroid formation: iodides. Lithium inhibits thyroid from working properly. Thiocyanates is what we use to treat hyperthyroidism. Phenylbutazone, sulfonylureas, amiodarone. Remember, amiodarone has iodide in the structure itself, so it acts like an iodide in this case. And interferon alpha. All those things will decrease thyroid formation, chemically possibly causing hypothyroidism, which is what I'm showing you here with this woman looking like she has low thyroid and her thyroid is small. Not her. That's not hers, obviously. Things that will induce the thyroid hormone are iodides. Remember, they can do either one. Hyperthyroidism caused by too much iodide is called a Jogges-Basedow syndrome. Amiodarone, again, like an iodide, can cause both hyper or hypothyroidism, as can interferon. Lithium, remember, inhibits thyroid from working. So if you abruptly withdraw lithium, you can get a drug-induced hyperthyroidism. Now, what happens with hypo and hyperthyroidism as far as effects on other drugs? Well, we know that when we have hyperthyroidism, it's a hypermetabolic state. So you're going to have an increase in heart rate, increase in stroke volume, increase in cardiac output, which will cause increases in blood flow, increases in clearance, right? And hypothyroidism would be the opposite. Increase in GFR, increase in basal metabolic rate, increases in clearance, etc. for a hyperthyroid patient, and hypothyroidism would be the opposite. I think that hopefully you just can understand and remember. So you're going to see generally an increase in clearances in hyperthyroidism and a decrease in clearance in hypothyroidism. Okay, so I guess we've gone over that. Increases in GI motility, increase in blood flow, increase in clearance, increase in half-life, etc. Or I'm sorry, decreased half-life because of the increase in clearance, etc., etc. All right, and I'm going to stop here, and we're going to get into some drugs here in a minute. Thank you for your attention.